say hello, and I see that you contribute a lot of difficult, challenging cases overall. Thank you very much.
Thank you. Thanks for the appreciation. But it's not easy to live through those cases.
Yeah.
Dr. Good evening. Hi, Eugene.
Hello.
Hi.
Hello.
Hi.
All right. The first case is from Dr. Vivek. So we'll start off. The Rainbow team will not be joining us. They finished their fellowship exam today, and there's a small farewell for them. So we'll go ahead with our cases. And all right. So once again, good evening, everyone. Thanks for joining in. We will be starting our session shortly. I'd like to encourage the attendees to put in their comments and their diagnosis and other helpful stuff on the chat. That will be monitored by myself and the panelists and the case presenter. Without further ado, we'll start off with our first case. Over to you, Dr. Vivek.
Thanks. So this girl we discussed in mid-February as well. So this time we had a follow-up MRI. So I just thought I will go through the history again, and then if the differential changes and if I have to do something more than what I have already done. So she came to us in mid-January. So at that time she had fever, fatigue, loss of appetite, acral rash, and eye swelling. Nihaal, you managed to, because I did send the photographs at the last minute. So did you get them?
Yeah, I have them.
Okay. So left facial swelling and rash on the eyelids, acral areas, high ferritin of 5,000, and with the not chronic fatigue, but a week of fatigue and fever. We did EBV, which was positive, VC-IgM. She was given symptomatic treatment, and she went home after 4 or 5 days of hospital stay in mid of January, third week of January. And then within 2 days, she came back with the right focal seizures, oromotor seizures, multiple episodes in a day, admitted, readmitted. And then this time, after the seizures, she became encephalopathic. So she had a first MRI done at that time. We'll show the MRI after the first admissions history, maybe. This is in the follow-up. So maybe I'll just do the history first. So when she woke up, so she was encephalopathic for a few days, and when she came out of it, she was very slow to respond, even though she was fully conscious, more like in a catatonic state, decreased facial expressions, dysarthric, and something like encephalitis lethargica. So that's what she was in. And at that time, she had this MRI done in that admission. This is the first MRI, end of January.
Yeah, the first MRI, quickly to summarize, we had some flare hyperintensities, periventricular regions, some areas in the perisylvian regions over there, along the bilateral putamen, the medial temporal lobes, and also involving the medulla. There was mild restricted diffusion on the diffusion-weighted sequences on the panel below. And then on the established sequences, there was no areas or concerns of hemostatin deposits or calcification or mineralization. Sagittal images again better demonstrate the abnormalities along the brainstem, especially the medulla over there. The visualized cervical cord did not demonstrate any focal or long segment lesions, nothing on the axial sections on the cervical cord. Post contrast, the edematous areas in the supratemporal brain did not demonstrate any enhancement. There was no enhancement also of the optic nerves or other cranial nerves. And the lesion on the medulla also did not demonstrate any enhancement at that time.
Yeah. And so she gradually, so we gave her steroids. We gave her IV methylprednisolone, changed to oral steroid. And as she was starting to get better, and there was some financial issues, so we didn't go to IVIG. And after 10, 12 days of hospital stay, she went home, getting better from her encephalitic lethargical-like state. Was that a follow-up video, Nihaal? Is there?
Yeah.
Yeah. So this is her in the follow-up.
अपने फ्रेंड्स का नाम बता सकते हो?
This is my child psychiatric colleague who is seeing her in the first follow-up visit after discharge. So this is her from the encephalopathic state.
साइक्लिंग करते हैं उनका भी बता दो आपके साथ.
Then getting better.
लव्या. Okay.
So she's telling
अच्छा,
a friend.
अभी भूख लग रही है आपको? खाना खाने में कोई इश्यू हो रहा हो, प्रॉब्लम आ रही हो? टंग पे ड्राइनेस लग रही है? ठीक है.
Right. So this is her. So this is her in a better state in the first follow-up in mid-January. On a small dose of oral steroid. We also gave her Sindupa for her Parkinsonian state. And then, so this state got better. So now when she came to me a few days back, she's near normal. Her mini mental state assessment was normal, memory is normal, and she's actually very active. So she's very fidgety. She has some vocal tics, but I would say she's 80% better than 90% better than what she was when she got unwell in that video. So we just did a routine MRI brain, follow-up brain MRI scan after 2.5 months just to see how things are. So this is the MRI which I wanted to discuss with you all.
Yeah. So this is in approximate period of 2 months later from the first MRI. And on top, we have the diffusion scans. And you can appreciate that there are punctate areas of restricted diffusion in the around over there in the right frontal centrum semiovale, also in the bilateral anterior aspects of the basal ganglia, some areas of the corona radiata, coming inferiorly, also involving the bilateral globus pallidus. So again, punctate areas demonstrating mild restricted diffusion. They don't correspondingly show significant low areas on the ADC, possibly in the subacute stage now. And on the flare sequences, again, you have these multiple discrete punctate areas demonstrating flare hyperintensities in the subcortical white matter and the frontal lobes over there. The bilateral deep brain nuclei, predominantly the globus pallidus, right more than left, right peritrigonal region over there. Yeah, and post-contrast, these lesions did not show or demonstrate any enhancement. Only on the optic nerves, I thought possibly the left optic nerve was slightly more thickened or edematous as compared to the right. The visualized pituitary or stellar region did not demonstrate any enhancement. No periventricular abnormalities, per se, no pericallosal abnormalities. You can see again the post-contrast study over here, the left optic nerve, the intracranial portion, intraorbital portion is slightly more demonstrating more enhancement, possibly on both sides now, but more on the left. And again, on the coronal images, you can appreciate that again, there is bilateral enhancement of the optic nerves, the left more than the right. This stage, given the history, previously, I think we discussed that the initial imaging findings possibly do not fit into HLH, if I'm not mistaken, Dr. Vivek, that was the consensus. Yeah. And then given the child had EBV infection, and I looked up if these discrete lesions present with HLH, and these first from a case series published, I think 1 or 2 years back, and you can see that patient 2 and patient 4 has some areas of discrete or small lesions, which are almost mimicking a neuroinflammatory disorder. These are the more typical imaging of what we expect for HLH, the posterior fossa involvement, the brainstem involvement, but patient 2 and 4, almost like a demyelinating or small vessel ischemic abnormality. Given the EBV, though the time frame is, I think, too early for EBV to present as a multiple sclerosis or clinically or radiologically isolated syndrome, they can have presentation along the deep brain nuclei, particularly in the pediatric age group. And these lesions can also have a similar imaging pattern seen in vasculitic disorders, other inflammatory, systemic inflammatory disorders. And the EBV infection, I just could find out that there are lesions which involve the deep brain nuclei, predominantly the basal ganglion thalami, can also involve the cortex. So I'm not sure if clinically it fits into a demyelinating disorder or an ischemic disorder. If the oligoclonal glands, I think, which was possibly one of the suggestions last time to be tested, was evaluated or not. and if there were any genetic testing for HLH, Dr. Vivek.
So blood ferritin is normal now. She didn't. So it was more like secondary HLH. You know, the patient one, more like primary HLH. Even though I would say at 14 you can present with the primary HLH following a EBV infection. So we have not done the perforin assay or genetic testing. We were more into secondary HLH. So patient one must be primary HLH, right? So 2 and 4 are more like secondary.
Yeah.
So she was more like secondary HLH. And NMO MOG is negative, CSF NMDA is negative, but oligoclonal bands I have to check. I don't know whether we did or not. At that time, we were not thinking of MS. So my differential now, am I dealing with CNS HLH is still active, or is just because the MRI was done on day 1 of her illness and these lesions might have already been there after day 10 and 15 and now they are resolving, you know, in the second MRI. And
yeah, but given the slightly bright nature on the diffusion, I wouldn't say that this is something which is 1.5 months or 2 months in timeline.
Right.
Possibly something more within the 2-week period.
Right. And optic nerve also definitely.
Yeah, optic nerve is also demonstrating enhancement left more than right. So that is again not a chronic feature, I guess.
And MS is a possibility here, is it?
Yeah, I mean, the imaging possibility is there because if you see, it almost fits into the pattern of this pictorial image or on the
HLH. Will they not have contrast enhancement in the active lesions?
Yeah, they will.
So that brings. So that will be odd then for HLH.
Yeah, that will be odd. If you see the panel on the bottom, it has some enhancement over there. So yeah.
So what does that fit in?
My question is, Dr. Vivek, you assume an EBV encephalitis. You have positive evidence for this.
Yeah.
Why are you considering yet another third possible diagnosis like MS? Of course, I don't know the answer, but are you sure, and Nihaal, that these images are the final images? There are sometimes conditions where the recovery clinic-wise, EEG-wise, imaging-wise, is not parallel. So the patient may look worse than the image and the other way around. My tendency would be to wait and see and repeat the image in a few weeks if everything goes well otherwise.
Yeah, that's what I thought because the thing is, I also, MS is not my differential.
Yeah.
So for me, it is more if it is CNS HLH I'm still dealing with, or is it a resolving phase of an autoimmune EBV encephalitis? That's what, and I clinically, when I see her, to me, she looks more, so parents will be shocked if I tell them that she needs more testing because they think she's so much better. So whether I should do a imaging again in a month's time so that see if how things are. It's just those optic nerve lesions. I cannot explain that with autoimmune encephalitic process.
The argument to do another imaging would be that you have then a kind of baseline for the future if there would be a relapse or whatever. Otherwise, you are in a black box.
And might overtreat also. She's not on any steroids now for last 4 weeks. Like I weaned off in 6 weeks' time.
But yeah, even the EBV and MS, I think it takes around 5 to 10 years, if I'm not mistaken. As MS, because this is too early.
And that's just conjunctural. Nobody knows. So maybe stick to a resolving autoimmune encephalitis, which is taking time, but you felt it is 1.5 months back.
That will be, I mean, because at least the diffusion, they usually don't show these changes if it's a 2-month interval change. I mean, if it would happen 2 months before, this is
because
possible.
ATC doesn't show it. So it has
it doesn't show it. So it's going into the T2 shine through phase. But still, I wouldn't put it beyond 1 month if you had asked me to guesstimate the.
When should I repeat imaging? Maybe a month or 3 months? I should wait 2 months, 3 months.
I think if she's clinically fine, then I don't think so. Maybe in 3 months otherwise, or 6 months.
Okay, 2 to 3 months maybe. 6 months will be too much for me.
Yeah, so 3 months should be fine.
Right.
If anyone else wants to comment, similar experiences. And Dr. Ashmi, Dr. Suhasini, Dr. Kamte, or anyone in the chat has similar experience.
Yeah, I just wanted to ask, did she have any other feature of systemic HLH other than the raised triglycerides? Raised ferritin. Did she have a raised triglycerides and any blood count abnormalities?
Yeah, so she had thrombocytopenia initially. Okay. So up to 60,000, I think she had gone down, platelets had gone, which had improved. Her triglyceride, her profile was normal. Triglyceride.
Okay. And what was the dermatologic opinion for the rash? Did they do a skin biopsy for the rash?
No, not skin biopsy. Dermatologists at the time, what did they say, folks? So I don't remember actually. So, is there a specific you were thinking of?
I don't know, cutaneous vasculitis, or we have to think of other connective tissue disorders as well.
It's a one-time event.
It was a one-time event. Okay. Okay.
And it's all resolved actually.
Yeah.
Clinically, Dr.
Clinically, yes.
Yeah.
This is high ferritin, Dr. Vivek, we have seen in many conditions, like couple of years back when COVID time, very high suspicion of MIS-C. So a lot of times ferritin were coming in thousands for like plenty of kids. So I have a feeling it's just an acute phase reactant. I don't know how much importance we should give to it and, as a marker for HLH.
Yeah.
If the other features are not there. So I am skeptical about the ferritin.
Was positive, platelets were low. So yeah, but still it will be acute phase markers. So yeah. So
yeah, that's what, because, because in our hospital also there was a high suspicion. So we've got like hundreds of kids with very high ferritin levels and nothing else. So of course, I think steroids were indicated definitely, but I'm not really sure. Even clinically, the other parameters of HLH I'm not sure if they're there.
Right. Because she had biocytopenia, she had low hemoglobin, she had low platelets, but yeah.
No marrow was done?
No marrow was done.
Okay. Okay, that's all.
Okay, there's a question in the chat. Comment in the chat. NMO spectrum, it was negative.
Yeah, MOG and NMO negative.
All right, maybe follow up.
Yeah,
in 3 months' time, Dr. That's
3 months. I'll do MRI. Thank you.
Deepak, if you're there.
Yes, sir.
Yeah.
This is an 8-year-old boy born out of non-consanguineous marriage with having perinatal insult of pneumonia on day of life 2. He required mechanical ventilator support and had an ICU stay for around 1.5 months. He is having global developmental delay and was treated as spastic quadriplegic CP until 2020-21. He had first MRI brain done in 2019.
Okay, so 2019, what was the presentation? Same developmental delay?
Same, sir. He's global developmental delay, but he's having more of dystonic type of CP with dyskinetic type with myoclonic jerks in the lower limbs.
Okay.
Can you perhaps say something about this pneumonia? Was it meconium aspiration on day 1 or 2 or any?
No, sir. Actually, baby was mother side after delivery, sir. His full term 3.2 kgs, and on day of life 2, he was admitted with respiratory distress.
Thanks.
Okay, so this is the MRI in 2019. On top, I have the flare sequences, axial, and you can appreciate that there is a bilateral striatal necrosis or gliosis, predominantly involving the putamen. There's also reduction of the caudate nuclei and the globus pallidus. Some punctate lesions in the bilateral deep parietal white matter on both sides. No cortical abnormalities, no brainstem or posterior fossa abnormalities, and the visualized cervical cord did not demonstrate any focal or long segment signal abnormalities or volume changes. On the diffusion, there was no corresponding restricted diffusion of the abnormalities of the dorsal striatum. and no other areas given, though these are from images from the films, but I could not appreciate any abnormalities on the diffusion weighted sequences.
And
So
yeah, Eugene, sorry.
yes.
So these images were at the age of 4 years. Am I correct?
Yes.
At the age of
he was
6 years.
kind of a stable situation, like a spastic cerebral palsy with microcephaly.
Yes, at 5 years, this was done, sir.
Okay.
Okay.
And since the past 2 years, they have came to our hospital. He's having gradually progressive, stimulus sensitive, uncontrolled jerky movements of both the legs, which are more on exertion and on doing any activity. These are absent in sleep. Now the child, this is gradually progressive and child is not able to walk even with support since the past 1 month, sir, and causing daily activity limitation. That there is no cognitive decline, there is no seizures, and on examination, there is dystonia more in the lower limbs and all equally, sir, in all the 4 limbs, and he's having microcephalies. So we repeated an MRI with MRS suspecting metabolic etiology. We have done basic metabolic workup, ammonia, lactate, VBG and Bera and Oftal all are normal, sir. And we went ahead with MRI with MRS in the last month.
So because it was gradually progressive and there's progression of dystonia and CP, is that right?
Yes, sir. Actually, we are suspecting any CP mimic could be any of the.
Because I know Eugene asked because of mycoplasma infection, if it can be a sequelae of that causing striatal necrosis.
Okay.
But clinically, you are suspecting a.
We are suspecting any metabolic or.
Okay.
I mean, this child had severe neonatal problem on day 1 or 2. Possibly also some lack of oxygen. It was ventilated for several weeks. So one option is that we deal with a residual change.
Yep.
You don't have an MR in the acute situation.
Yeah. So that kind of limits our at least the imaging possibilities. So we'll get to that after looking at this MRI. So this was after 2 years, and again you can appreciate bilateral striatal necrosis or gliosis, more along the putamen, also involving the caudate nucleus. The thalami are relatively spared in terms of volume and signal changes. No SWI abnormalities in terms of mineralization or chronic hemosiderin deposits. Some punctate foci in the parietal white matter, which we have seen in the previous scan. The posterior fossa structures did not demonstrate any abnormalities. The corpus callosum volume is maintained. Brainstem volume is maintained. The visualized cervical cord is also normal in volume, and there were no signal or focal abnormalities over there. So we're dealing with bilateral striatal atrophy or predominant parietal striatal atrophy or necrosis. Angio was done, which, as expected, did not demonstrate any abnormalities. Spectroscopy was done, and these were the peaks from the putamen, and could not appreciate any diagnostic abnormality over there. There was no significant elevation of lactate. The Na and choline ratios are normal. Creatinine is normal. So spectroscopy doesn't add much, at least in the chronic stage of the child, given that the first scan was done at 5 years, and now we are 3 years into the, almost more than 3 years into the illness. And based on that, I think the imaging is slightly non-specific, I would say. The differentials are wide. The striatal necrosis can present with mitochondrial disorders, chronic stages of organic acidurias. If they have choreas, PDE10A mutation can cause that interferonopathies, and can also be present post-infective or post, such as mycoplasma can present with bilateral striatal necrosis or atrophy. So these are the imaging differentials. I think given that we have scans only in the chronic stages, it is slightly wide and slightly limited. At least that's what I think. So I'll open the case for the panelists to add their comments now.
I just want to ask about the regression. Like, was this child walking independently and then he stopped walking?
No, ma'am. There is no regression of milestones. Just since the beginning, he's having global developmental delay and is not able to walk.
Okay, so what is the, so what is like how, what is the progression that you're looking at?
But in meanwhile, he used to, previously he used to walk with support, ma'am.
Okay.
Like in 2020, 21 and 22, He's able to walk with support at least. But since the past 1 year or half year, since October, this child is not able to walk even with support, and these stimulus sensitive jerky movements are gradually increasing, ma'am.
Okay, so I mean, could it be possible that there's an underlying epileptiform process which is causing his regression? Like, do we have an EEG?
EEG was done, ma'am, initially, but not this time. It was normal, ma'am.
No, because I think one of the things we need to see, are we dealing with a static cause and a pseudo regression because of just worsening movement disorder or worsening epilepsy? Or are we dealing with actually a progressive disorder? And then how much, you need to do a genetic workup? I mean, I guess you need to do it anyway, but but yeah, you need to, because like one of the differentials they discussed is a one-time insult, like a pneumonia.
Yeah.
That time they discussed, and now, but then we have to explain why he's worsening now.
Yes, ma'am. So we suspected genetic. It only we're planning for a genetic testing, ma'am. But the financial issues. So once they are ready, we want to send them.
May I ask, Nihaal, can these changes be residual following hypoxia? As an old-fashioned person, I try to make just one diagnosis if it's possible, and not a dual or trouble.
Yeah.
And here you have a start in the neonatal period with long ventilation. You have secondary delay and microcephaly all explained. And now you have some, it's not a real deterioration, but you have some new symptoms, which you also see sometimes in cerebral palsy. So that's the question, is this just one?
Yeah, one time insult. Deepak, is this? Yeah. Deepak, just before I answer, is this a term child or a preterm?
Full term, sir. Full term, 3 kgs. But
Eugene, I would say static is possible, but I would say more of an infective one rather than hypoxic, because the thalami are completely spared. Even the corpus callosum and the surrounding white matter is completely spared. So I think post-infective changes is a possibility, given that the child had pneumonia. And mycoplasma, as it pointed over here, can have these striatal necrosis or gliotic changes. Hypoxia, I would say there would have been some involvement of the ventrolateral thalami, given that there's such extensive involvement of the putamen. So I wouldn't pull out static, but I would say more of an infective cause than the hypoxia.
Yeah, because if you take injury in the term baby and a preterm baby, preterm baby, they have predominantly periventricular leukomalacia, and term baby predominantly have deep basal ganglia changes.
The corticospinal tracts also are slightly, I mean, they look normal, the plics are normal, there's no thinning of the corpus callosum, at least there should be some focal thinning, but yeah. So yeah, static is possible, but I would say more infective rather than only hypoxia.
Okay.
So I think the judgment should be made on the clinical progression. I mean, because we are now in the chronic stage of imaging, so we'll rely more on the clinical phenotype than the imaging phenotype now.
Okay, sir.
Okay, to our next case, Kirti, if you're there.
Yes, I'm there. So this was a 1-year female child born of 3rd-degree consanguinity, firstborn, without any significant perinatal issues. And she had presented with complaints of abnormal eye movements. And on examination, they were typical continuous pendular, it was a pendular nystagmus in all directions of gaze without a null point. And there was also a background of mild motor developmental delay, whereas cognitively the child was very bright, and reflexes were present with a bit of central hypotonia. And this nystagmus they had noticed right from 1 to 2 months of age, and it has been persistent. And they feel that the speed of the nystagmus has reduced a bit over the last 1 year. However, it is still present. So for developmental delay with nystagmus and central hypotonia, imaging was done.
Can I ask here, any information about visual acuity, about fixation, about following objects? Because this is important in terms of differential diagnosis.
Correct. Right. So the vision was very good. The child was fixing and tracking. There was also approach of objects present. So the vision was good, and the fundus examination was also normal. So the local eye ocular causes of nystagmus were ruled out.
So suspecting any myelination abnormality?
Yes, suspected. Yeah, first I suspected any hypomyelinating disorders. Okay. However, reflexes were easily elicitable, or sometimes even structural abnormalities of brain present with nystagmus. So basically, hypomyelination versus structural were my differentials.
Okay, sure. Yeah. Just to add, I think the child had a left eye coloboma from the ophthalmology.
Yes, yes, there was correct. There was left eye coloboma. I forgot. Yes, but it wasn't very significant as the vision was good. Is what the ophthalmologist had said.
Got it. All right. So scan at the age of 1 year completion. On top, we have the T2 weighted sequences. I think to appreciate that there's extensive T2 homogeneous hyperintensity involving the cerebral white matter, periventricular regions, deep white matter, these deep central white matter, the internal capsules are demonstrating these T2 hyperintensities. The brainstem, especially the pons, demonstrates T2 hyperintensity is going slightly into the cerebral peduncles over there. The ventral aspect of the medulla also is slightly hyperintense. So on the sagittal images, you can appreciate that the pons predominantly is hyperintense. On T2 weighted sequences, the corpus callosum is also hyperintense. On the corresponding T1 weighted sequences, there is mild hypointensities of the corresponding hyperintense changes on the T2 weighted sequences. Diffusion, there were some bright areas on diffusion, but they really did not correspond on the ADC sequences. And on the flares, the T2 hyperintense changes were demonstrating corresponding hyperintense changes on the flare sequences. There was no rarefaction or cystic changes within the abnormal white matter. Given this imaging finding, thought of a possibility of a hypomyelinating disorder and the involvement of the brainstem, a possibility of Creutzfeldt-Jakob-like disease. And again, these are just clues for the leukodystrophies or the hypomyelinating disorders presenting with brainstem abnormalities. As seen in our index case, it probably fits into the PMLD type pattern rather than the other differentials over here. And clinically, nystagmus, as Katie has pointed out, I mean, this is just a radiologist, for a radiologist. I thought that the primary myelination-related disorders can present with early onset or nystagmus. So yeah, we're looking at hypomyelinating disorders or some delay in myelination related disorders rather than genetic leukodystrophy or demyelinating disorder.
Okay.
And there were no structural malformations.
Yes, my main question was that usually hypomyelinating disorders will not have diffusion restriction. Whereas...
Yeah, they usually don't. I mean, they should reverse on the ADC. Okay. So this is actually, I think, possibly artifactual or not true restricted diffusion.
Okay.
If you compare that with the ADC sequence, they should be dark completely, but they're not. And the one over here on the right frontal region is artifactual. It's not there on the diffusion sequence. So this is more focal rather than diffuse or homogeneous.
Okay. Okay. Thank you. Thank you.
So no, I'll open the case now for the panelists.
Yeah.
If they want to add up on anything. Yeah.
I have nothing to add. This is a hypomyelinating disorder genetically, and you need to do genetic testing, I think, if you can afford.
Yes, yes, we are planning for that.
Yeah, I think it's what we call GJC2 related. Yeah. This condition is now called GJC2 related disorder.
Okay, so PMLD is removed.
Right? Yeah, PMLD.
Okay.
Yeah.
Right. Yeah.
I think the term has changed now.
Okay, okay, right. Thanks, Dr.
No, GJC1 or
GJC2.
These are two.
GJC2, I think.
Yeah.
There's a comment from, okay, Aisa has said hypomyelinating disorder. Yeah, we agree. Manoj Naik, at least 2 imaging findings are needed for diagnosing hypomyelination. That is, I think, if the child has been scanned before 12 months of age, Manoj, this child was scanned at 1 year of age. So it should be you should be pretty confident to call this as hypomyelination at this age now. Yeah. Okay. Next two sets of cases from Pune. Jayant, if you're there.
Yep. I'm presenting a case of a 3-year-old boy with acute history of fever, vomitings, and loose stools for 3 days. And this child was admitted to us with the main complaint of one episode of seizure, which was generalized tonic-clonic semiology. And in the background, the child had a normal family history, perinatal history, and developmental history. And on examination, the child was febrile. However, the vitals were stable, and throughout the admission, the child did not have any BP fluctuations, and there was no rash in the examination. On neurological examination, the child had a low GC with pupils bilaterally active. The child was irritable, and there were no obvious cranial nerve deficits. There were brisk reflexes, and the rest of the neurological examinations were normal. And the systemic examination, there was no organomegaly as well. After admission, the child also had one episode of right focal seizure, which was aborted by midazolam, and the child was eventually loaded on levetiracetam. And the child was shifted to PICU, and we planned for an MRI. And we also did an LP, which was normal, had borderline elevated proteins. The child was started an empiric cocktail of ceftriaxone and acyclovir. So we'll go to the MRI images.
This is after the MR, Jayant?
So, yeah, this was after the MR, sir.
Okay. So we'll have a look at the MR first. Yeah.
Yes, sir.
So I have the diffusion and ADC sequences over here. On top, you can appreciate that there is subcortical, cortical confluent abnormalities involving the temporal lobes, the occipital lobes, and the parietal lobes. Some areas of the frontal lobes, predominantly on the left side. And again, showing corresponding ADC sequences have low signal changes on the ADC as compared to the diffusion-weighted sequences. T2 and flare, the abnormalities are more conspicuous and predominant on the diffusion sequences. There's possibly slight edematous changes in the cortex, so there are some subcortical hyperintensities in the temporal lobes and the occipital lobes, but the main findings are illustrated on the diffusion and ADC sequences. Given that the edematous changes, you can have some paucity of the cortical vessels because there is brain edema. But other than that, I cannot appreciate any hemorrhage or necrosis or calcification on the SWA sequences. So predominant changes of subcortical, cortical diffusion restriction and sorry. Yeah, Jan, now you can go to the follow-up, the labs.
Yeah, so we thought of acute encephalitis syndrome, and we have done an LP. However, the LP had a normal cells, 2 cells, and protein of 44, and the sugar was normal, 37, with a corresponding RBS of around 57. And in the peripheral smear, nothing was there. Hemoglobin was 11, TLC was borderline elevated, 11,000, and the CRP was 16.4. And we could only get PCRs for Japanese encephalitis, Chandipur, and HSV 1 and 2 from NIV. And however, the BioFi was not affordable. And the rest of the liver functions and renal functions were normal. And dengue was also negative. We also got a swab for COVID and an influenza swab as well, because there was an epidemic going on. Both came back negative. So I just wanted to ask, like, what exactly, can we get any etiological clues from this pattern of encephalitis we are dealing with?
Okay, this is what I found clinically. I think you probably covered most of them in your evaluation. Infection is most common for the encephalitis syndromes. Imaging pattern wise, it fits into the ALE-RD pattern, which can be diffuse or can have these central sparing abnormalities as seen in your case. This is a case series from Dr. Kamte, I think is there in the panelists, and you can see that at least this they can have posterior predominant involvement. It's not necessary to have the entire cerebral hemispheres having these changes. So imaging wise, I would say it fits into the ALE-RD type pattern. The etiology wise, I think viruses and toxic infection can be the most common cause, but again, the list is vast. So at least by radiologically, I can say that it fits into the acute encephalitis syndrome with imaging features of ALE-RD. Toxic encephalopathy is a differential, but I don't think it fits in the clinical or history wise. So yeah, imaging wise, that is the diagnosis, and yeah, infection and toxic causes are the possible etiologies. Which one is causing that? It's a little difficult to say on imaging.
All right, sir.
Yeah, I'll open the case for the panelists if they have anything. There's a question of, is there any hypoglycemia which can have these posterior changes? But
no, sir, there was no hypoglycemia.
No. Okay. And the seizures were biphasic or just single episode?
So there was one episode before the admission and one episode after the admission, and after that it was fine.
Okay.
So I just had a query. The pattern of diffusion restriction which you see in alert is usually of that central semioval, or this is more common, or that is more common?
Yeah, so these two patterns are common, the diffuse one and the central sparing one.
Okay.
But they can also present with hemispheric abnormalities as demonstrated over here.
All right.
So it's basically an exotoxic injury. So that is the main imaging manifestation. It can be diffuse, it can be hemispheric, it can be central sparing.
Okay. Okay, sir.
I think if Dr. Kamte is there, he has many. I think he has many papers on this topic. If he wants to add any comments or anyone else. So clinically, any further testing required? If I think that's the main question here. So viral PCRs had only these 3 viruses or 4 viruses?
Yes.
Only
3 viruses. Actually, ma'am, these are the 3 viruses which are screened at NIV. So the patients are not affordable, so we couldn't do anything else other than these 3. We couldn't screen for adeno also. So
adeno, rotavirus, influenza, enterovirus, Coxsackie, bacterial are also known to cause these patterns. So all right. We move on to our next case. Meetu, is there?
Yes, sir. Yeah. So, sir, she's a 6-year-old female child, case of T-cell lymphoblastic lymphoma with tumor lysis syndrome. Along with tumor lysis syndrome, she also had AKI. She developed 2 episodes of right focal seizure followed by altered sensorium on 14th day after the onset of symptoms. On examination, she had GCS of 6-7, normal cranial nerves, hypotonia with brisk reflexes and bilateral extensor plantar, as well as she had hypertensive readings, following which we did an MRI.
Okay. Yeah, we'll come back to this after the MRI. Just to point out that the child, Meetu, if you can just illustrate the treatment before the MRI, on what drugs and what medication she was on.
So before the onset of seizure, she was only on hydration, allopurinol, antihypertensive medication, anti-epileptic Levipil, and was on anti-edema measures, Dexa and 3% NaCl. That's it. Chemotherapy has yet not been started.
Okay. Okay. So we have typical confluent abnormalities, changes of acute hypertensive encephalopathy or PRES, post-reversible encephalopathy syndrome. Though we have more anterior involvement over here in this case, frontal involvement demonstrating subcortical cortical abnormalities, T2 and flare hyperintensities. Again, posterior cerebral hemispheres have these changes. So the supratentorial abnormalities fit into the acute hypertensive encephalopathy or the PRES-related changes. On the cerebellum, on the left side, there was this T2 hypointensity, predominant hypointensity region with some cystic areas, and on the corresponding T1 hyperintensities. The SWS sequences will better demonstrate that this is a primarily predominant hemorrhagic or hemosiderin-related lesion. And there were also some punctate areas in the left parietal lobe demonstrating these SWA changes. No restricted diffusion of the supratentorial white matter abnormalities and also the cerebellar abnormality. PRES, as the imaging pattern fits, it is pretty typical as seen in our case. The question was, what could be the cerebellar lesion? And the cerebellar lesion possibly fits into a cavernoma or cavernous malformation. These are the examples which are pretty similar to our case. It fits possibly into the type 1 cavernoma or cavernous malformation. These are the genetic factors. Acquired causes are pretty rare for a cavernoma. They can be present in post-radiation, so hence the treatment was asked. But this child did not have any radiation done. I don't think this is a tumor.
Yes.
It most probably fits into a cavernoma with other small cavernous angiomas in the left parietal region over there. So press and cavernous angioma is what I'm thinking of. So yeah, I'll open the case for the panelists if they have any further comments.
I also thought this was a cavernoma. Nihaal, perhaps you can teach me or us. Sometimes it's mentioned that there is a kind of a popcorn
calcification. That's
I mean, this looks like popcorn, no?
Yeah, popcorn calcification on the it's most described on the CT scan rather than the MR. It has this lobulated kind of calcification. The SWI usually is more homogeneous, but on the CT it has this contour, the convex contour type calcification resembling a popcorn. So that's the description for a typical cavernoma.
Okay. Okay.
Yeah, there was a comment of CT, and I think Bulent has rightly answered that there's no need of a CT scan for this. Yeah, I agree.
Okay.
Do you recommend any follow-up to see the evolution of this cavernoma?
No, sir. The patient has been referred for chemo to some other hospital.
Okay. No, because they have some tendencies to bleed.
Okay.
So yeah, just have a look at any posterior fossa symptoms or any symptoms of raised intracranial pressure, which might need evaluation.
Okay.
No spine imaging. That is one of the questions from Bulent. Yeah.
No, sir. No.
Yeah. The cavernoma wasn't symptomatic. No, there were no posterior fossa symptoms.
No, sir. At that time, there was no posterior fossa symptoms. There were no.
Okay. Yeah. Got it.
Okay.
All right. Thanks.
Thank you, sir.
Next case will be discussed by Dr. Sabit and Dr. Rashmi. Over to you.
Yeah, so this is a 8-year, 7-month-old boy. So initially he presented to us in September with what looked like a small transient ischemic attack, which lasted for a very short period, and then he recovered from it. And he was seen that time by our pediatrician who thought that there was a murmur presence. He was referred to the cardiologist. And when the cardiologist did an echo, they thought that he might have Takayasu arteritis. So, following this, he was started on. I think this is a little more detail about what happened in September. Okay. So, following this, he was started on anti-inflammatory medications, and he was also started on aspirin. So, this was in September. So he was an ex-prem. He was at 30 weeks gestation, and his development was completely normal. He was attending mainstream school and all of that. So following this, in September, we thought, okay, we've got on top of the thing. So he got IV methylprednisolone, and followed by that, he was started on steroids by our rheumatologist. And we had arranged follow-up, and we had discussed his scan, I think sometime in October or beginning of November. So second, in November, he had a further episode of stroke. So he presented with UMN hemiplegia in November 2022 with slurring of speech, and his NIH score at that time was 10. He had no bowel or bladder symptoms. So that time, when he presented to us, I think Dr. Nihaal can look at the imaging. We were in a quandary on whether, we should give him TPA because he's presented early with the stroke, whether we should do whether he needs any vascular surgeon input, whether he needs any surgery and all of that. So anyway, following that, nothing was done. He was managed conservatively, and we had started him on aspirin and clopidogrel. So there are 3 MRIs for this child.
Got it.
And the third presentation was in February this year, where he just had a headache. He did not have any symptoms of stroke, but to be safe, he was admitted and he had this third MRI scan. So I have 3 questions at the end once Nihaal finishes. I'll tell them once Nihaal finishes those 3 questions, what I want to be answered here.
Okay. Over to, I think Dr. Savit will do it because I think he has reported the scans. So Dr. Savit, over to you.
Yeah.
So this is the imaging done at the initial presentation. So in the brain, what we see is acute infarct, which is involving mainly the frontal lobe on the left side. So there are corresponding changes on flare. We don't see any large vessel occlusion. The ICA and this one MCA is patent. Though we do see some focal areas of blooming, which is in the sylvian fissure. Probably these must be thrombus within the small or distal M2 or proximal M3 branches. So there is elevated perfusion seen in the region of the infarct. Probably this only means it's a luxury perfusion. There was an occlusion caused an infarct and probably recanalized later. That's what it would suggest. Whereas the angiogram does not show any large vessel occlusion. So this was at the initial presentation. So when we did the imaging of his neck vessels and the arch, we see there is focal narrowing of the arch branches. So this is the left subclavian. The origin is narrowed. The proximal aspect of the left common carotid is not visualized. So this is the bifurcation. So this is severely narrowed or occluded. Again, there is a narrowing of the right subclavian. And this is the right common carotid, severely narrowed. The arteries distal to the carotid bifurcation, they are normal in caliber. The basilar and the vertebral artery distally are normal in caliber, probably mild stenosis of the origin of the right vertebral artery. This is a contrast imaging, something like a vessel wall imaging, which we did for the neck vessels. So what we see is wall enhancement involving the aortic arch, and these are the common carotid arteries. You see there is a wall enhancement which is involving the common carotid arteries. If we see in the subsequent images, wall enhancement which is seen involving the common carotid arteries, the vertebral arteries does not show much of an enhancement. And as we go distal, there is no enhancement in the cervical ICA. So mainly there is involvement of the arch and the proximal arch branches showing wall enhancement. Again, the CT confirming the same findings which is seen on the MRI, wall thickening involving the arch and arch branches with the narrowing of the origin of the arch branches. The vessel wall imaging of the intracranial vessels did not show wall enhancement or circumferential wall thickening involving the intracranial vessels. On the first imaging, it is in tachyarthritis. However, the infarcts are embolic infarcts because from probably the inflamed vessels in the neck causing stroke. Second time, this is when he presented to us with acute symptoms. Now we see new areas of infarct, mainly involving the lentiform nucleus, the caudate head, and the corona radiata, showing diffusion restriction. Now, there are also areas which are not showing flare diffusion hyperintensity with no corresponding changes on ADC. These could be older areas of infarct. So on flare, there is no corresponding changes on flare. So it only suggests that this is an hyperacute infarct. He must have presented to us in less than 4 hours since the onset of symptoms. There are these changes, chronic changes related to the prior insult. What we also see is a flare vascular hyperintensity along the left convexity, suggesting that there is slow flow in the MCA branches on the left side. And here we see a long blooming signal, intravascular susceptibility signal, suggesting a thrombus within the proximal MCA. There is a perfusion defect in the left MCA territory, and these are arterial slow flow artifacts due to collateral flow or slow flow within the MCA branches distal to the occlusion. So again, the imaging suggests that there is an embolic occlusion of the MCA with hyperacute infarct. we did the imaging of the neck also. Then there was no MR angiogram shows complete occlusion of the left M1-MCA, no visible flow signal beyond it. Most of the changes in the neck were stable compared to the prior examination. There was persistent wall enhancement. There is persistent severe occlusion of the left CCA. There's persistent severe stenosis of the common carotid on the right side, and there's persistent, these images showing this persistent wall enhancement in bilateral common carotids. So the changes in the neck were stable. However, the new finding was a occlusion of the left M1-MCA.
Yeah, I think that we have described. So yeah, third scan.
This is the third scan. What we now see is only gliotic changes involving the sites of prior infarcts with some volume loss. What is interesting is there is complete recanalization of the MC on the left side. There is no blooming or any hemorrhage within the prior infarcted area. So the current scan shows complete recanalization of the occluded M1-MCA with flow in the MCA branches, distal MCA branches.
Got it. All right. Thanks,
Okay.
Dr. Yeah, Dr. Rashmi.
Yeah, so my 3 questions is, the first one is I think in November 22, Dr. Savit and I, along with lots of neurologists, we had an extensive discussion on whether this child should have TPA, because he presented in acutely and he was almost within the 4.5-hour window and all that. However, on reading through it, the cause of this infarct is embolic, and secondly, there is inflammation in the vessels. So TPA carries high risk of hemorrhage. So I wanted to know whether the thrombolytic therapy is something someone has given in Takayasu arteritis, whether it could be considered, or whether it should not be given because of the inflamed vessels. So that is my first question. My second question is, after the second episode of stroke, he is on both aspirin and clopidogrel to prevent further episodes of stroke. Is it wise to continue, or would anyone suggest anything more than this? And my last question is whether any vascular surgeon would operate if there is a hyperacute stroke. Because most people say that if it is Takayasu, it's an inflamed artery, so nobody will want to touch it. So whether you really need a vascular surgeon input in this, or whether it should always be managed conservatively. So these are my 3 questions for the panelists, because we are just thinking about these things.
Can you specify perhaps your third question? You said a vascular surgeon.
Yes.
Which region do you consider to be tackled, perhaps?
This was after the second stroke, isn't it, Dr. Savit?
What Dr. Rashmi is trying to ask is there a role of endovascular or mechanical thrombectomy in the child? This was discussed. The only issue with this child was the access. So access to remove the intracranial, the clot in the MCA is via the carotid. So both the carotids, the left carotid being completely occluded, so we didn't have an access to go to the MCA. The other option is, can we do a direct puncture of the neck vessel? Now, direct puncture of a carotid bulb or a proximal cervical common carotid artery is possible, and it is being done. So it will be slightly challenging to do a direct puncture of the internal carotid artery. If mechanical thrombectomy was possible, then the option, in a child, mechanical thrombectomy is definitely possible. When I say mechanical thrombectomy, we go endovascularly and pull out the clot. The problem in this child is the access. So either we had to recanalize the occluded left common carotid artery, or we had to do a direct puncture of the direct access of the common internal carotid artery in the neck. Now, both are challenging and have a higher risk. So the favor of going conservative over this heroic attempt of recanalizing an occluded common carotid or direct puncture, conservative was considered. If there was an access, even if there was a small significant side stump of a common carotid artery, it is easier to puncture and easier to manage it post procedure. So mechanical thrombectomy definitely would have been an option, given that there was a good access to reach the site.
No, the thing I wanted to ask is, Dr. Savit, mechanical thrombectomy you can do if there is, obstruction and the vessels are not inflamed. Takayasu arthritis vessels are inflamed, right? Yeah.
Madam, the etiology for the or imaging the etiology for M1 occlusion, it's embolic. It is not. So embolus probably must have arisen from somewhere in the neck and then reach the M1 MCA. So definitely there is a role for mechanical thrombectomy for the clot in the M1 MCA. If it was a vasculitis related stenosis or occlusion of the artery, there is no role of mechanical thrombectomy.
No, I agree. But I was asking, when you do mechanical thrombectomy, you have to go through an inflamed vessel. So would you be at risk of causing more bleed because you're going through a vessel which is already inflamed, right?
The only challenge is to cross through the common carotid artery. If you are able to cross the carotid artery, there's no risk of bleed. There's only risk of perforation. Means these are all friable vessels.
Friable vessels. That's what I was saying.
So there's a risk of perforation. There's definitely a risk of perforation. So we have to. This one idea is to weigh the risk versus benefit. Probably I think the idea of the because child was improving and the perfusion imaging did not show much of a deficit, the option of conservative was chosen over mechanical thrombectomy. The challenge of crossing an occluded inflamed arthritic vessel is we may perforate the vessel and cause a local hemorrhage or probably rupture of the artery.
Yes, exactly. So that day we transferred this child to the stroke unit because we don't have the vascular surgeon in our facility and nor in Apollo Hospital. So we transferred the child to the stroke unit. And that day night, he seemed to improve. So they did not do anything. But the following morning, he worsened. So they repeated the scan. I think I don't have those images. And they found that the perfusion study, it did not exceed. It was the same as it was before. So they opted for conservative management. So my question to the group was, in such a case of Takayasu arthritis, has anybody done any mechanical thrombectomy? Or usually you will opt for conservative management because of the pathophysiology of this condition? That was one of my questions. And the second one was on TPA. Has anyone used TPA or is it completely contraindicated because of all the vessel wall inflammation and things like that? I think everybody's gone silent.
Silent because we have no experience.
That's what I was telling. I think the father of this child is probably in this meeting. I asked him to attend because I said it is very complicated and it is not very easy to, answer all the questions. So.
And the child is now on aspirin.
Aspirin and clopidogrel. So both, he's on both aspirin and clopidogrel.
Okay.
Would you give anything else? Or, initially the rheumatologist from the first, when he presented first, thought aspirin only was overkill. But obviously with the second stroke, we added in both aspirin and clopidogrel after lots of discussion. And now currently he's on aspirin and clopidogrel and he's not had any, touchwood, no further strokes since the last 3 months from November.
Okay, thank you.
Yes, he is on steroids. Someone's asking in the chat. He is on steroids. So initially he was given IV methylpred, which also was overkill, we thought. And then he was started on a low-dose steroids. Currently, he's on a low-dose steroids and is gradually weaning off because his inflammatory markers are all normal. And as you can see from the latest MRI scan, there is not a lot of inflammation. So someone has said prompt initiation of anticoagulation. You mean low molecular weight heparin? That was given. Yes. Low molecular weight heparin was given in this child.
There's a comment from Manoj that thrombectomy was done, but there was access through the carotid. So yeah.
Okay.
On the Q&A section.
Yeah. The Q&A says someone has said that if thrombectomy is done, then they should be access to the carotids.
Yeah. I think Mario says, and article. I'm not able to open it, but yeah, if you can just check that.
Yeah, there are 2 articles here. No, I'll just check that. Yeah. Would anyone give more than aspirin and clopidogrel? Have you tried anything else?
Madam, in adults at least, this one, any stroke management based on the etiology, if it's an artery embolic or atherosclerotic etiology, then it is always a dual antiplatelet. If it is cardiac, it is a anticoagulant with an antiplatelet, like atrial fibrillation or something as a cause. Okay. So in an adult, if someone had presented like this, where we consider this as an artery embolic, dual antiplatelets is a treatment of choice.
Okay, fine. So he's on the right treatment then. Yeah.
Yeah. Now in most of the adults, if it is an artery embolic, then it will be due to an atherosclerotic stenosis. So which we will treat it if it is significant, more than 50%, by putting a stent. Now in this case, we don't have that option. But what is very, very unusual is it's an occluded common carotid artery. Why is he forming a thrombus at the carotid bulb? Probably is the thrombus is forming somewhere at the carotid bulb and is being thrown to the intracranial circulation. Now, does this thing happen in any vasculitic process or tachycardia? I don't know. This is the first time I've come across something like this. Most of the time, what we see is complete occlusion of the artery and patients developing a hemodynamic stroke rather than an embolic stroke.
The other thing which I was discussing again with the Narayana team was that when you're on dual antiplatelet and if you don't have a stroke for 3 or 4 months, then I think this is from adult papers, again, not in children, they go to one antiplatelet treatment because that's what she was telling me. But anyway, in this case, we've decided to keep on both.
Yeah, Dr. Rashmi, there's a long message on the chat. Maybe you can just check that from.
Yeah, there's a long message. Yeah. High restenosis rates following vascular intervention range from 37% to 62%. Usually always prophylactic intervention. Patient who undergo emergency extracranial reconstruction with stenting should be carefully followed to ensure long-term patency. However, thrombolysis alone may fail acutely due to presence of extracranial and intracranial lesion and high clot burden. The collateral circulation in this case of advanced Takayasu facilitated mapping for thrombectomy eligibility as multimodality CT imaging allowed precise depiction. Considering the often poor arterial access related to multiple occlusive lesions in the supraortic vessels and vessel friability, in the setting of severe inflammation, medical management has more often been employed. Historically, management included standard treatment, IV, TPA, oral anticoagulation, or a combination of these. However, reports of efficacy are conflicting in some patients. That's very helpful. So overall points, she seems to say that it's a rare cause of stroke, often involving younger patients with extension of carotid system. Mechanical thrombectomy may be considered for eligible patients with large vessel occlusion stroke, secondary to based on clot burden and medical futility. Supraortic vessel stenosis or occlusions are common with advanced TA. Angiographic mapping is critical for endovascular treatment subtyping. Pharmacological therapy is a mainstay of treatment. Careful optimization, neurological and rheumatological resilience, paramount. Yeah. So overall, I think everybody is favoring medical management rather than going for anything else from what I can see. And there is a nice article here, which I will have a look through. Thank you, Dr. Aisa.
Yeah. Got it. All right. Thanks, Dr. Rashmi. Maybe, yeah, we'll have a look at the articles and.
Yeah. Thanks, Dr. Savit.
Yeah. Thanks, Dr. Savit. Dr. Suhasini, over to you.
So this is a 6-year-old girl. She came to us in February. So she was premorbidly normal. She presented with history of fever and she had a rash on day 4 which disappeared within 2 days. Then she developed altered sensorium. She was not recognizing her parents and she came to us with this encephalitis-like picture. She had neck rigidity, she had altered sensorium, and she also had tonic posturings. So then an MRI was obtained and she was started on supportive treatment, IV fluids, antibiotics, acyclovir, and she was actually in the ICU. I did not see her at that time, but she improved. Her sensorium improved and she was noted to be rigid and she had some tremors, resting tremors in the fingers. So at that time we thought this was like a Parkinsonian-like picture with post-encephalitic Parkinsonism, and she was started on Syndopa. But 2 days later, she again developed altered sensorium and she was not responding. So this was kind of an odd presentation. So initially we thought maybe the Syndopa was making her sedated. I've never seen that side effect, but that was stopped, but she still continued to be very sedated, very obtunded. And we repeated, the initial CSF had just shown 30 cells, normal biochemistry. A repeat CSF was obtained, which again was normal. And the repeat imaging was done. So then, yeah, I'll tell about the repeat.
Yeah.
After the repeat, after Nihaal discusses the imaging, I'll discuss what we did.
The MRI is before the videos, Dr. Swansky?
This MRI is before the videos, yeah. The
Okay.
first MRI is before the videos.
Okay. So first MRI, I cannot actually appreciate any abnormality. I'm not sure if that was reported as a normal scan.
There were some basal ganglia changes, I don't know.
This is on the 15th. The follow-up one had on the 18th.
Oh, there were actually two of them, like.
Okay.
Two scans.
Yeah, two scans. The one later, the one after this has changes.
Okay, there was actually both of them had basal ganglia changes, but the second one had markedly worsened changes.
Okay. All right. At least the ones which I have here.
Okay. This 15th one did not have changes.
Yeah,
okay.
15. Then I think he had a CT scan.
Yeah.
Which was mentioned as high possibility of viral encephalitis. And after that, I think there was an MRI on 18, 3 days later.
There's actually a third MRI then.
Okay,
I'm
okay.
sorry if I'm not into the third MRI. Okay.
So you want me to show the MRI?
Yeah, sure.
So this is the one I have on the 18th. Is this the last one or the one, the second?
No, there's actually one which is worse, a third one which I haven't sent you then.
Okay, no problem.
Like we can discuss this one, yeah.
Sure. Yeah, so the one 3 days later after the 15th Feb MRI, you have these area of restricted diffusion in the frontal white matter. So the centrum semiovale there, but predominantly in the periorganic regions and also predominantly involving the dorsal striatum. And also some areas in the medial temporal lobes, the left half of the brainstem, the midbrain, or the cerebral peduncles, corresponding low signal changes on the ADC sequences, and some areas which do not demonstrate any restricted diffusion, rather facilitated diffusion is demonstrated in the hypothalamic region, the brainstem, extending up to the pons. The extent of the abnormalities are better illustrated on the flare sequences and the T2-weighted sequences. And you can appreciate that there is involvement of the bilateral basal ganglia, predominantly in the caudate and the putamens, and also the capsular region extensively, more on the right side than the left. The medial temporal lobes are involved, right more than the left. The brainstem is involved. There is pairing of the cerebral peduncles, the ventral aspect of the cerebral peduncles and the red nucleus. There's again involvement of the inferior portions of the brainstem going down up to the dorsal aspect of the pons. And similar changes on the flare sequences with these edematous hyperintense changes demonstrated over here. Post-contrast study could not appreciate any significant enhancement of the supratentorial abnormalities. The deep brain nuclei and the brainstem do not demonstrate any significant enhancement. I could not appreciate any optic nerve or other cranial nerve enhancement, and no changes of hemosiderin or mineralization in the abnormal areas. So these were the MRI images, and I think this is the follow-up video.
Yeah, actually, I've sent you, if you can, I mean, is it possible to see your WhatsApp? I've just sent you the 6th, there was a one on 6th March.
Okay, let me just check.
The repeat after the worsening, second worsening.
Okay.
And after the second worsening, we gave her steroids and IVIG, and she actually improved. I'm sorry, I thought I'd sent you both the 5th, 18th and the 6th March, but you've got the two earlier MRIs.
Let's see what we can make of these. All right. Okay. Yeah. So significant progression, bilateral basal ganglia involvement, bilateral capsular involvement, extending up to the temporal lobes, the brainstem. These are the ADC sequences. This does not demonstrate. Okay. The T2 changes again. You have these bilateral basal ganglia abnormalities, capsular abnormalities, progression in the brainstem. Some volume loss in the supratentorial brain, also in the vermis in comparison to the first MRI. Again, this image probably depicts the extent of the lesions involving the deep brain nuclei, predominantly dorsal striatum, the capsular white matter, the subinsular white matter, and also brainstem abnormalities. Yeah. So, yeah, these are I think this is the latest one.
Yeah.
And
yeah. I'm sorry.
that's all right.
Yeah.
And already the comments have come up as a possibility of the Wilson's disease or the anti-DR2 encephalitis. I think both of the images possibly fit in terms of differentials.
Clinically, she did not behave like Wilson's. She had an acute onset encephalitic illness and a biphasic course of illness. So we thought of something immune mediated. That's why we gave her steroids and IVIG, and she actually improved after that. She was conscious. She started responding. So
I think that is okay.
Yeah, this is now she's better. This is after the second worsening. She was obtunded for quite a few days, almost for a week.
Yeah.
And after steroids and IVIG, she improved.
Okay.
Significantly. So, but I don't have a diagnosis on her. And we're planning a PET scan to see if it could fit into basal ganglion encephalitis.
Yeah. So is the measles primary driver for the parainfectious?
I don't know. The measles, she did not leave any scarring, like just staining, no post-measles staining, just measles-like rash for 3 days, that's all.
Yeah, I would agree with the parainfectious autoimmune based on the third MRI. There's a comment on uremic encephalopathy.
No, there was no uremia.
No, there was no uremia. Yeah. And there's ANEC, but again, this does not fit ANEC.
Yeah.
Yeah. So yeah, I'll open the case if anyone wants. Influenza, dengue.
Yeah, we tested for dengue, not for influenza. But again, the biphasic illness was very atypical.
Yeah.
She improved and then she again worsened.
And now again she's improved. Is that
now
right?
Again she's not. The second time she improved only after steroids and IVIG.
So the D2R encephalitis, I think on imaging also there's improvement post-treatment, if I'm not mistaken.
Okay, then I have to repeat that because I have not got a post-treatment MRI.
Yeah. So that might be helpful in terms of the diagnosis.
Okay.
Atypical ADEM. Does it fit clinically into an ADEM? Was there encephalopathy? I think
there was encephalopathy, but radiologically, I don't think it fits into ADEM.
Any infections last week?
Last week, I mean, no, there was no repeated, there was no infection associated bursting. The only thing which happened was she gave her syndopa, but I don't think that should cause this.
Dr. Kavita says improved on rituximab. Had similar patient. Yeah. Indrashis also agrees possibility of anti-DR2.
DR2, yeah. So resources are a problem. We can't get anti-DR2 done.
Yeah, but I think there are papers post-treatment. There's improvement on the imaging at least.
Imaging also. Okay. Yeah. I'll get an MRI repeated maybe after a month to see.
Okay. Dr. Kavita's patient had chorea and tremors too, so acceptable movements. Okay. Okay, so I think we are concluding with parainfectious autoimmune etiology, likely DR2.
DR2, okay.
The main possibility.
Okay, thank you.
There was no, I think, putting it out there, but there's no dog bite, no insect bite, such thing.
No, it's your dog bite.
Question from Isa, is it just one episode?
Yeah, I mean, the same episode was kind of biphasic. Yeah.
Okay, if there are no further comments, possibly a follow-up MRI, and we can get back to that in the next.
Yes, I'll share the follow-up MRI.
Sure. All right. Thank you.
Okay.
To our last case, Dr. Priya, if you're there.
Yeah. So she's the 15-month-old female child who was previously normal, head cough since 20 days and more in the night time, and also fever which was low grade, not coming daily but sometime, more in the night time since 15 days. On probably 10th day of illness, she had one focal seizure and lasting for few minutes. And after that, child was fine. There was no encephalopathy. But again, after 10 days, she had status epilepticus that was focal. And since then, she was unresponsive. She was admitted to in some private hospital. There they have done some CSF and MRI imaging. MRI imaging was reported that there is meningitis, but we have discussed that MRI here in our hospital, and they told that there is no changes of meningitis. And when we received child was in the shock and with the gasping respiration, so she was intubated. CSF was done inside in our institute, and that was showing high protein, but rest of the thing was normal. Outside CSF was done on which was showing 10 cells, 90% lymphocytes, and 10 ependymal cells. We have treated child with the antibiotic and on the line of the meningitis. After CSF culture was showing E. coli, which was sensitive to gentamicin, amikacin, and polymyxin. So could it be contaminant? And after treatment with the sensitive antibiotics, child was in vegetative state. So we repeated and there was posturing also. So we repeated MRI, and MRI was showing, I have shared that MRI with you. And again, CSF was repeated on the last 12th, that was normal.
Okay.
So my doubt is, okay, you just.
Yeah, go ahead. Go ahead, Priya.
Are we dealing with the tuberculosis based on the MRI, or it was really bacterial meningitis?
Okay. So this is the first MRI on 17th. These are from the film. So T2 sequences on top. There is mild, possibly very minimal reduction of the volume, and some changes possibly in the pulvinar thalamic nuclei over there, but not very significant, I would say. But if you see on the FLAIR images, again, it is slightly brighter than normal, the thalamic portions over there. But other than that, I could not appreciate any extraaxial collections and no other focal lesions in the brain, at least on the T2 and the FLAIR sequences. And this is the post-contrast sequence, and I cannot at least appreciate any abnormal enhancement in terms of meningitis. And there was no basilar exudates or basilar enhancement. I don't have the images here, but yeah, there was no typical feature.
Probably it was not there.
Yeah, so typical features of TB were, what we expect are not there, at least on the initial scan. The brainstem and cerebellum on the axial sequence, on the cerebral sequences appear normal. And then this is a follow-up almost 2 weeks later. And then,
yes, 17th, yes.
Yeah. So you have progressive changes of volume. Was steroids given by any chance?
No, steroid was not given.
Okay. So progressive.
Only child was on ventilator, so
Okay.
of more than 48 hours. So before extubation, steroid was given.
Okay. So progressive supratentorial atrophy compared to the first scan, and you have these white matter changes predominantly in the deep and subcortical regions in the frontoparietal and temporal lobes. Predominantly in the frontal and temporal lobes, as you can see on the fourth image over there. Diffusion, could not appreciate any corresponding restricted diffusion. Post-contrast, again, no abnormal enhancement demonstrated over there. So I possibly can say that the typical findings of TB are not elicited on both the scans, but the follow-up imaging has these progressive changes, leukoencephalopathy type pattern with the supratentorial brain atrophy. The CSF, I think, is important. Was it contaminated? Because the initial picture does not look like a bacterial infection. Is that right, Dr. Priya?
Yes. Probably it could be contaminated because it was sensitive to only gentamicin, amikacin, polymyxin. It was resistant to our routine antibiotics.
Okay.
So polymeningitis would be very unusual in this age, I think, unless you have some kind of communication, kind of a tract from the skin to the spinal cord.
Okay, but there was no there was no sacral sinus and something. There was nothing like.
So would autonomic Would that be a possibility? Again,
Autoimmune?
Yeah. Or are they just post-infective changes with leukoencephalopathy and atrophy? But the atrophy is, as someone has pointed out, is significant given that the child did not have any steroid medication and there was no seizures or per se.
Yeah. And even after status epilepticus also, the MRI was normal. First MRI was normal.
Okay.
And after coming
and
to
there
our
were no
institute,
hypoxic or
there was no
hypotensive
hypoxic
episodes.
event. There was no hypoxic event. So could it be E. coli meningitis, or should I give methylprednisolone?
Okay, meningitis, at least on imaging, we don't have meningitis.
Okay.
Inflammation of the meninges, but so those features are not there.
And there is no neuropsychiatric manifestation.
Yeah.
Child is initially also she was in vegetative state. Now also she was in vegetative state, but she was having posturing. So we repeated MRI. EEG was done, which was showing some encephalopathic changes. Nothing else. And now the illness is almost
SSP,
1 month.
Is that possible or?
SSP,
I think EEG,
the child
EEG was normal, I guess.
Encephalopathy, but not the SSP changes in the EEG.
Okay.
Or should we consider some metabolic etiology? Neurodegenerative.
Neurodegeneration, yes. Which metabolic I'm not able to point as to a metabolic disorder without the diffusion changes.
HIV is negative for this child. Okay.
Paul G, was there epilepsy? The pattern, did it fit Paul G? The imaging is not typical of Paul G. Martin, if you agree that.
There is
the thalamic changes possibly can be Paul G, but the follow-up, would there be extensive white matter abnormalities and a supratentorial atrophy? That is, and there was no restricted diffusion at all of the thalamus changes. So, yeah. Is the patient any epileptic drugs?
Yes, she is on phenytoin.
Okay, so phenytoin can cause atrophy, supratentorial atrophy, but white matter changes again, that would be slightly atypical, I guess.
And viral panel has been sent. Report is still pending. And HIV is negative for this child.
No cytokine storm or anything like that, no? Yeah.
No.
Okay. And no raised inflammatory markers also, I guess.
ESR was 10, CRP was 19, and repeat also it is normal.
Okay. Question of interferonopathy, first scan is normal. So again, without any calcification, they usually are slightly asymmetrical, the involvement. So, and no skin lesions, I guess, no chilblain type abnormalities.
No skin lesion.
And no, COVID was tested by any chance?
RT-PCR is negative.
Okay.
Okay.
So the question is, do you want to go ahead with steroids? Is that
should I go with the steroid, or since they are not affordable, so should I send workup for the metabolic also?
I don't think it's metabolic because the first scan would have shown something. And if it's there within a 2-week period, then I would expect some diffusion changes. I would probably thinking in autoimmune type or para-infectious type rather than a metabolic.
Okay.
The medication one, I'd probably leave it to the neurologists who are there on the panel if they want to comment upon it.
See, even if it's an infectious condition, right? The pathophysiology of the brain damage is usually because of it's immune mediated.
Yeah.
So giving a dose of steroid will be useful, but the question is how much you want to give. If you're thinking very severe and all, ADEM and all, we give high doses. Otherwise, you can give a small dose of steroids as well.
Okay.
Okay, there's a comment of you can give pulse dose steroid trial. There's no.
Okay. Okay.
So I think we're looking at possible contamination based on the second CSF and the absence of any meningitis in the first and second scan actually.
Yes, possibly E. coli that was contamination.
Yeah, yeah.
Oh.
So maybe give a dose of steroids and see if the child improves clinically.
Okay.
There's a comment to combine that with IVIG. If you're not sure of sepsis, well, the child have sepsis. I mean, yeah. Would you do IVIG, Dr. Rashmi? Or just start with steroids first, I guess?
Yeah, so IVIG also can be considered, but obviously it's expensive.
Yeah.
So with IVIG, see, there are some viruses where you can exacerbate the problems. If you have an enterovirus, for example, they say that you should not give steroids. Having said that, there are some categories of enterovirus also which respond very well to steroids. So overall, the consensus now is the damage from the viral encephalitis or anything is immune mediated. So you should always consider giving immunomodulatory agents. So if they're affordable, then you can go for IVIG. Otherwise, you can consider steroids. The question is what dose you give. I mean, that is variable. If you want to give a pulse dose or whether you want to give a slightly lesser dose, you'll have to decide.
Okay.
Was a PCR sent? Yeah.
PCR has been sent. Report is pending. Okay. And we can't send this oligoclonal band and everything because they are costly and they are not affordable at all.
At least they don't look like the isolated syndromes or the MS type lesions for oligoclonal bands, if that is what they're inferring to. So
okay.
I think post-infective encephalitis is the more likely possibility. Yes.
Okay. Okay.
Yeah. Okay.
Oh, thank you.
Yeah. Thanks. So let's see. Okay, there's a comment for NMDR. I think Dr. Indrashish patient is
it is costing almost 4,000 to 5,000.
Yeah.
So not possible.
Okay. Okay. All right. So I think that's our last case. And yeah, once again, thank everyone for joining and for active participation on their chats. Helpful comments. And we'll see you again 2 weeks later on 28th of April. I'd like to request all to send their cases by 26th of April. And that's my email address if you want to contact and send the cases.
Thank you. Thank you.
Right. Thank you.
Okay. Thank you so much. Thank you very much, everybody.
Thank you. It was very good. Nihaal, would you have 2 or 3 minutes for me?
Yeah, I do. Yep. Do you want to wait till people leave again?
Perhaps. Well,
yeah.
It's not that secret.
Okay.
Well, my question is, you have kindly suggested that I join the SPINacademics scientific board or whatever it's called.
Yeah.
You hear me?
I do.
Yeah. Of course, it was an honor. I joined, and then a few days later, I got a mail that I'm expected to give a talk about PCH at a virtual meeting, 20 minutes. Yeah. Of course, I can do that in terms of scientific content. Yeah. And later on, I got a mail how to do it and all the registration stuff, and Zoom and so on. Yeah. When I, as oldie, started to read this, it looked to me so complicated. Yeah. I fell into coma. So
did you,
could you imagine that later you are helping me?
Yeah, I will. We will help you out again. No issues. Myself and Kesh and Jay, the person who is emailing you, will be able to help you out. Like how you did it for the IPNT, the ICNA recording.
This would be great. This would be great.
I hope the topic is fine. PCH.
The topic is excellent.
Yeah.
I have no difficulty to speak 20 minutes about this. My problem,
It's the technical stuff.
I'm sorry about this, that the technology is...
we should be able to help you out. No, yeah, you don't worry about that.
If it's something new for me, I try to just to get a dead reflex. Look like some animals. When they are threatened, they pretend to be dead. And that happens to me.
Got it. No, we'll help you out. Don't worry about that.
Okay. Thank you so much, Nihaal. It was again, and all the other people, it was again very informative.
Yeah, and thanks for your opinion on the case. I'll probably get back with an INAD gene.
Yeah. Pleasure.
All right.
Take care. Have a good weekend.
Yeah.
Bye-bye, everyone.
Bye-bye. Yeah. Bye-bye, everyone. See you soon.